Hello. Welcome to a brand new medical surgical nursing lesson. My name is Jessie Wheatley and I'll be facilitating this lesson. Please be sure that you have your notebook ready to take notes and you have your textbook available for reference. I encourage you to highlight any key points that remain unclear and to be sure to email me for any questions. This lesson covers an overview of the nursing care of patients receiving oxygen therapy. We will review RN assessment, best practices, and monitoring for these patients. We will also cover different O2 delivery systems, and we will discuss nursing care for patients with tracheostomies. We know that oxygen is a gas that's essential for life and is used as a drug in with a sick patient to relieve hypoxemia, which is low levels of oxygen in their blood, and hypoxia, which is decreased tissue oxygenation. Conditions outside the respiratory system also contribute to the need for oxygen. Examples of these conditions are heart failure, sepsis, fever, poisoning, decrease in hemoglobin and hematocrit, or even poor hemoglobin quality that affects oxygenation. The oxygen content for atmospheric air is about 21%. O2 therapy is going to be prescribed when the needs of the patient cannot be met by room air alone, the 21%. You want to apply oxygen to anyone who is hypoxic. You want to make sure that the therapy delivered to the patient is humidified appropriately. And the goal of therapy for oxygenation is that we use the lowest fraction of inspired oxygen, which is called FiO2, to have the acceptable blood levels without causing any harmful side effects. By the end of this lesson, you should be able to review the indications for use of various types of oxygen delivery systems. You should be able to understand the RN management involved in protecting the patient's skin, the mucous membranes, and the integrity in patients who are already receiving oxygen. You should understand the nursing care of patients with tracheostomies and the prevention of any complications associated with the maintenance of respiratory stability through this type of modification. You should already by now know that when a patient is hypoxic, they need to receive oxygen. Let's talk about some RN assessment reminders. Remember that the goal of therapy with oxygen is to use the lowest fraction of inspired oxygen, FiO2, to have an acceptable blood oxygen level without causing any harmful side effects. So we have a patient here that's going to be receiving oxygen therapy and we have applied it. We want to monitor ABGs. We want to monitor oxygen saturation for patients receiving oxygen. We know that ABGs is the best measure for determining the need for oxygen and for evaluating whether the effects of oxygen are working. Okay, but we also know that ABGs are very invasive, so the fastest and non-invasive way to check this would be pulse oximetry. We want to monitor the rate and the depth of our respirations for our patient. We want to do that every hour for any patient that has hypercapnia and CO2 narcosis who is receiving oxygen by mask or nasal cannula. You want to use aspiration precautions for this patient. You want to make sure that the head-bed is elevated. Use aspiration precautions, especially in patients that are altered level of consciousness or patients that have an ET tube in place. You want to assess the skin of the patient. You want to look under the mask and under the plastic tubing every shift for patients receiving oxygen to make sure everything looks good. You want to assess their nares and make sure that everything looks good there, and the elastic band every shift and make sure that it's not too tight. You want to go ahead and inspect their oral mucous membranes every shift as well, especially if they have an ET tube in place. We'll talk about ET tubes in another lesson in more depth. You want to use sterile technique if they have an ET tube or they have a tracheosuctioning or a tracheostomy opening. You want to make sure that patients that are receiving oxygen therapy have the correct nursing diagnoses for their therapy, and also you want to make sure that you decrease anxiety and monitor confusion, because acute confusion can be related to the hypoxemia. Oxygen therapy is going to present certain hazards and complications that the RN will need to make sure that they've included in the teaching, and they need to make sure that they're monitoring. The first one would be combustion, where oxygen and smoking would probably not be recommended, and would make sure that the patient is taught about not smoking. Oxygen-induced hypoventilation in patients whose main respiratory drive is hypoxia may become a problem. Your textbook goes in more details about oxygen-induced hypoventilation. Oxygen toxicity may happen related to oxygen concentration uh, uh, being delivered. Observe any patient receiving oxygen greater than 50% FiO2 for early symptoms of oxygen toxicity, which is dyspnea, non-productive cough, chest pain, and GI upset. You need to understand the duration of O2 therapy and the degree of lung disease for your patients. Another complication is absorption atelectasis from the dilution of nitrogen levels of nitrogen and alveoli collapse. Your textbook goes in more details about that if you're not able to understand that. Another one is the drying of mucous membranes. We want to make sure we're watching the patient for dried mucous membranes. And the other one is infection, and infection can come from nebulizers and other delivery systems that are not being kept clean. We want to make sure that our patient teaching is including that patients need to know how to clean their O2 equipment. Let's now talk about low flow delivery systems for oxygen. In low flow delivery systems, the oxygen delivered is variable, and it depends on the patient's breathing pattern, since the room air dilutes it. So there's a little bit of room air dilution as far as low flow oxygen delivery systems. Your textbook covers a pretty good example of the difference between high flow deliveries and low flow delivery systems. A list of low flow delivery systems. An example is nasal cannula, like in this patient right here. The nasal prongs are going to be a low flow delivery system that delivers 25% to 40% FiO2, and it can be dialed to flow at 1 to 6 liters a minute. So remember, room air is at 21%, and this one can deliver 25 to 40% concentration of FiO2. Okay? The face masks, there's different kinds of face masks. Some face masks are going to fall in the low flow delivery systems. The simple face mask that this little girl here has is going to deliver between 40% to 60% FiO2, and if the flow rate is high enough to flush the CO2 out, it's going to deliver a better delivery system. So we want to make sure that we're watching the flow rate as well. We have the partial rebreather masks and the non-rebreather mask. The partial rebreather mask is going to deliver about 60 to 75% FiO2 if the flow rate on the meter is keeping the bag 2/3 full. The non-rebreather mask is going to deliver between 80% to 95% FiO2 if the flow rate is able to keep the bag 2/3 full. So you want to make sure that the flow rate in the oxygen delivery is high enough on the wall that the non-rebreather mask is getting, the patient is getting the correct FiO2 they need. When we talk about high flow O2 delivery systems, high flow systems include the Venturi mask, the aerosol mask, the face tent, the tracheostomy collar, the T-piece that deliver accurate levels of oxygen that meet the patient's oxygen needs when properly fitted. A high flow system delivers concentrations from 24% to 100% FiO2 if the flow is between 8 to 15 liters a minute. Your textbook has a very good example that talks about high flow delivery systems. The Venturi mask is featured in this, and you can read a little bit more about that in your textbook. Other non-invasive positive pressure ventilation measures would include any techniques that are being used to keep positive pressure to keep the alveoli open and improve gas exchange without the need of intubating a patient. NPPV can be used with oxygen or just on room air, and it is now being used to manage dyspnea, hypercapnia, acute exacerbations of COPD. We're using it for cardiogenic pulmonary edema, for acute asthma attacks, and we may also see examples of that would be CPAP and BiPAP. Transtracheal oxygen therapy is a long-term method of delivering O2 directly into the lungs using a small flexible catheter that is passed in the trachea after a small incision is made. The patient must be stable and optimally treated before they are considered for home and long-term care. The nurse and the respiratory therapist are responsible for teaching the patient about the equipment they're going to use at home, any oxygen sources, delivery devices, humidity sources, and safety aspects of maintaining that setup at home. Now, let us talk about tracheostomies. Tracheotomy is the surgical incision into the trachea to create an airway. Tracheostomy, on the other hand, is the stoma or the opening that results from the tracheotomy. Okay, so we have an example of a tracheostomy, a trach tube here, sorry. The type of tracheostomy tube is going to depend on the specific needs of the patient. Your textbook covers those specific needs. Most trachs are like this one here, disposable these days. Most are some are reusable, but most of them are going to have a disposable inner cannula. The cuff, what's called the trach cuff, let's look at it right here, right there. The cuff may or may not be present on trach, so there may be a cuff trach or a non-cuff trach. It may or may not be used in acute care patients on mechanical ventilation. You're going to have them mostly cuffed with a cuff trach. Just because it is cuffed, it doesn't mean that the patient can't aspirate. You want to make sure that the patient's head of bed is elevated even when they have a cuffed trach that is cuffed. Okay, the inflation line or the pilot balloon may not be accurate. So the pilot balloon, the inflation line, marks how much inflation has happened to the cuff. The inner cannula, which is right here, goes inside this, may have an inner cannula. Most of them have an inner cannula, and you want to inspect the inner cannula. You want to suction and you want to clean PRN. You want to make sure that the patient's inner cannula is being taken care of based on your facility policy. My biggest pet peeve is when an RN says that I don't know how to take care of the trach and I just let the respiratory therapist take care of it, but yet the respiratory therapist, their job is to maintain the airway, and they don't have orders, and they may not have a policy, facility policy that says the inner cannula is cleaned by respiratory therapy. So that is a very good way for you to kind of assess and make sure that you understand what your agency policy is regarding trach care. Let's talk about fenestrations. A fenestrated trach, the fenestrations happen on the cannula, on the outer cannula, or so when they say they have a fenestrated trach, it just means that it has a little bit of those little openings. They differ in what they look like from manufacturer to manufacturer. When an inner cannula is in, fenestration serve as a double lumen tube functionality, but when the inner cannula is out, and a red plug is in place, the patient can breathe out of their natural airway. We usually don't plug trachs unless the patient is stable, so make sure that you understand the stability of the patient. One thing I wanted to add is as you get ready to go ahead and cap a trach because the patient is stable, you want to make sure that you understand whether it is cuffed or uncuffed and whether it is cuffless. Usually when we are discontinuing the trach and we need to start capping the trach, we'll go ahead and switch the patient to an uncuffed trach. So how do these patients get these trachs? The patients are going to have trach either as a scheduled procedure, but most likely it's going to be put in as an emergent procedure. So it's going to be an emergency that calls for them to end up with a tracheostomy. In this picture, this is a procedure of putting in tracheostomy. A tracheotomy, which is a surgical incision, can be an emergency procedure. I already said that. Some indications that a patient is going to need a tracheotomy is going to be acute airway obstruction, the need for airway protection, any laryngeal trauma, any radiation to structures in the neck that cause problems with breathing, any airway involvement during head or neck surgery. It's going to require a patient have one. The nursing diagnoses and collaborative problems for patients requiring a trach include impaired gas exchange, impaired verbal communication, imbalanced nutrition, risk for infection, impaired oral mucous membranes, impaired self-concept, and impaired social isolation. So those are going to drive the care for this patient, and preoperatively, we want to make sure that the plan of care includes those. Post-operatively, after they've had the trach put in, immediately after, the care is going to focus on making sure that this airway remains patent. Okay, you want to confirm the presence of bilateral breath sounds, and you want to conduct a thorough respiratory assessment often. At least every 2 hours after they have stabilized, but often before then. You want to assess the new tracheostomy stoma site to at least every shift to make sure that it's healing correctly, that there's no drainage, there's no redness, there's no pain, there's no purulence, and it doesn't look like it's getting any infection. What are some of the ways that you're going to watch the patient for several things? Think about how you're going to watch this patient for tube obstruction. Think about how you're going to watch this patient for tube dislodgement. How are you going to think about how you're going to watch this patient for accidental decannulation. How are you going to watch this patient for pneumothorax, subcutaneous emphysema, bleeding, or infection? The highlights for a nursing care for a patient with a trach is going to prevent tissue damage from happening, to ensure that the patient has warm air and they're getting enough humidification through their trach. You want to suction this patient. You want to make sure that you're providing tracheostomy care. I talked about that a little bit earlier. You want to understand your facility policy on what and who does what. I just don't like the thought of somebody having a tube sitting in their throat that is supposed to be changed every shift, but it hasn't been changed the last 3 days because we weren't sure who was going to change it. Okay, you want to provide bronchial and oral hygiene. You want to make sure you understand the nutritional status of this patient and how having a tracheostomy is hindering or causing problems with nutritional status. You want to communicate with this patient. Communication is key. Just because they have a trach and they can't talk, we just don't forget about them. We want to make sure that we're supporting their psychosocial needs, and we want to make sure we understand the criteria for weaning them off the trach. Usually, most people in the acute care setting will probably wean off the trach. In the long term care setting, they will probably keep that trach for a while. Thank you for listening to this lesson. We have reviewed oxygen delivery systems. We've reviewed the nursing management involved in protecting the patient's skin and mucous membranes when they're receiving oxygen. You should have a better understanding of the nursing care of patients with tracheostomies and the prevention of any complications associated with the maintenance of a respiratory stability for this type of modification. If you have any questions whatsoever about this lesson or the corresponding notes, you can email me at the address below. Thank you and have a blessed day.